the county why we are getting positive mothers, besides having the prophylaxis available for them. We have 8 graduations which are conducted annually. So far we've done 3 A graduations, that is in LCRH, that is Lodwar County and Referral Hospital. That is, we had one in St. Patrick's for last year, and we've also conducted one in Kakuma Mission. And the A graduations are being supported by the T and the partners. And it has always been a learning session for the PMTCT mothers and for the entire community. And we've had even the other mothers who have not delivered come and witness and also hear testimonies of those who are able to get HIV negative children. And in these Hay graduations, we've involved local women leaders like the Chair Lady of Maendeleo ya Wanawake and her team. And you saw this in the first slide, where she was the one leading the children to cut the cake. That is our graduation for St. Patrick's. You can see we were ready to give these presents to our children, to our Hay, and their parents. What have we been able to do as a county to our adolescents? There is what we call OTZ, that is Operation 000. There is Red Carpet Program for adolescents. There is Adolescent Focal Persons Identification. There is Flexible Clinic Hours / Days for adolescents. And there is also End of Year Adolescents Party. I'll take you through each one of these. On Operational 000, adolescents, these targets to ensure that adolescents participate in their own health, to ensure 0 missed clinic days, 0 missed dose, 0 viral load. And what we target in Operation 000 is to allow the adolescents to speak to themselves, to allow the adolescents to take responsibility over their health, to allow the adolescents to identify what is healthy and what is not healthy for them. And it's done in clinic setup for the age 10 to 19 years, and adolescents have time during the clinic day or during the club day. Adolescents have time to talk to each other. And staff supporting these adolescents are trained on adolescent package of care. That means they have the skills on how to support these adolescents, speak to one another or open to one another. And OTZ support team, we have OTZ focal person at management level, we have facility and OTZ champions, that is at the clinic level. Red Carpet Program for adolescents targets mature adolescents, that is 15 to 24 years. Those are the ones who are in secondary or tertiary level. And it aims to ensure that adolescents are linked, are enrolled, they are suppressed. And these adolescents are given VIP cards which they present and are allowed to be seen without waiting. And our partners supported us to come up with this because we realized we were missing out adolescents. Initially, we had not scheduled a clinic for adolescents or a separate setup for adolescents, and we were missing them out because they were not comfortable queuing with adults. So we came up with this so that whenever an adolescent comes to the clinic, even if it's not their clinic day, they are given a priority, they are seen, and they are allowed to go. Adolescent spokespersons, they are found at the county and facility level. We have one SCASCO who is in charge of adolescent issues, who oversees adolescent issues across the county. And at facility level, we have one adolescent identified in every facility to support other adolescents during clinic days. And there are so many things that we in this adolescent. This adolescent should be free of stigma, should have gone through the OTZ club successfully, and should have set an example to the other adolescents. So there are qualities for one to be an adolescent leader or focal person in that very facility. So in every facility, we have identified adolescent focal person who is able to reach out the other adolescents. And through these focal persons, feedback is provided about the quality of service to the concerned parties or to the facility. We have flexible clinic days for adolescents. Adolescents are seen over the weekend in some of the facilities. Some of them are seen after 5, that is their comfortable time, and some of them even prefer to be seen at around 7 in some of the facilities, that is like outcast facilities. So this flexibility has given a chance for our adolescents to access care in every facilities, in the various facilities. They are not restricted to their clinic days. They are not restricted to their time, because some of the facilities or the clinics operate between 8 and 3. So some of the adolescents prefer to be seen after 3. So there is flexibility in clinic days and hours for adolescents, just to adjust to what they want or what is preferable for them. We've been able to organize end of year party for adolescents, and this happens every end of the year with support from our partners. And the forum allows for interaction and open discussions amongst the adolescents. And for those who might have been doing so well, they are given a chance to teach the others how they were able to, why they are able to progress well in their clinics. And for those who are suppressed, they're able to talk to those who are not suppressed, what they are doing for them to be able to get the outcome of suppression in their health, that is during the time that they are taking the drugs. So this end of year party normally creates a session where the adolescents are able to speak to one another. The adolescents are able to talk to their healthcare providers, and it's also a time where we allow them to expose their talents. We allow them to make presentations, and their awards, where we award those who performed well in school and those who did something that was impressive during the year. We are able to award them during that time, and this has really helped us as a county. It has really helped us as an HIV management team to be close and to be able to understand our adolescents and to be able to support them. Thank you.
Thank you very much, Nancy, for those highlights. I think some of the ideas that you're implementing in Turkana, or other ideas being implemented in Turkana County, are really great and important. And they're also, I like the fact that the local culture, or the culture of the local people, is integrated when coming up with such solutions. For example, when you talked about the maternal shelters, where they're not made out of cement, they don't have cement floors. So like, some of those approaches are really great. From my end, I have maybe 1 or 2 questions. So I'll start with the first, and then we could have that discussion, and then I'll throw in the second, and we'll also be taking in questions from the audience via the chat box. So my question is, what are the attitudes of the men who are engaged? Like at the point where you're engaging with maybe the chief to call these meetings with the men, how helpful are those meetings? Like, do we see a drastic change in the attitudes of the men during these engagements?
I can say the attitude of men changed after the first training that we had with the ward administrators and the chiefs. After the consecutive meetings, during the consecutive meetings that we rided on, as I said earlier, after the training that we had with the chiefs, we were able to come up with a work plan, and we rided on the chief's work plan. So it was no longer a health issue. It was the local leaders' issue. So once we were able to bring them on board to understand that we have this problem, we had high positivity of over 20%. and they were like, and there was something that was necessary for them to do. They took up the task and moved on. And because they were able to organize the meetings after the training, to me, that was a positive attitude. And even after, during those meetings, they were not taking it as if it is health issue. It was now their issue as administrators or as leaders in the community. And I can tell you that we could go to some of those meetings. Like in one of the meetings in Kalokol area, we could go to those meetings and just sit back and go back without saying anything, because the chief and the wazee or vijiji were able to really give out the information adequately as needed. So to me, after the training, they were able to take up the mantle. They were able to take up the responsibility to empower the community. And even after that, we were able to get a report that some men were taking their women, escorting their women to ANC. But the gap that is still there is, with the escort to the facility, they are still hesitant, maybe to go in with them for testing. I see there's still a gap, but they are able to bring women for us. For now, we are going a step ahead. Like, can we? Yes, you brought for us these women, but are you able to stay with this woman and take her through what we are doing in the facility? So to me, the meeting and the men engagement has changed the attitude of men towards the PMTCT, towards the ANC, and also towards hospital delivery. Because initially, any woman who goes to deliver in the facility, as I said earlier, is considered to be a coward. And even the man will feel like he can't sit in the midst of the other men, because they will say your woman can't deliver at home. You are like the real woman if you deliver at home. I think that is disappearing slowly by slowly. Men are appreciating women. When they come out of the hospital with children, they appreciate, not as earlier. Thank you.
Great. I think you addressed that quite adequately. My second question would be on the VIP cards that are given to the mothers from the areas that are farther from the facility, and also to the adolescents. What is the acceptance rate of these VIP cards by the people who are in the locality, considering you give a VIP card to someone else and they'll come into the facility and not queue, which generally means I will walk into a facility and find several people waiting to services, but then I have to get ahead of the queue. So what is the acceptance of these VIP cards from the local people who are from around where the facilities are located?
Thank you, Kevin. Remember, some of these things that we are doing might not have reached the entire Turkana community. And I must tell you sincerely, stigma is still high in Turkana. So you will find that the VIP cards are not known to everyone. If I'm served with the VIP card, not everyone in my locality, or even at times not even all of my family members, know that I've been served with a VIP card. But what we do is to ensure that we've already capacity build the healthcare providers or everyone in the facility to know if this person comes with this card, kindly give a priority. But on the other side of the community, maybe a few people know that Nancy has been served with a VIP card, or the people that I've disclosed my status to. Those are the people who know that I have a VIP card. So I can say it's not something that has like that people are like proud and maybe going with it all over and telling people I have a VIP card. It's something that once you're served in the facility, you just have it with yourself, and maybe the few people that you've disclosed to know maybe that you have a VIP card, but the entire community will not know that you have a VIP card. Remember, still stigma is an issue in Turkana, which we are still working through these meetings that we are having, engagements we are having with the community to dispel the stigma and allow the community to accept the generation that is infected with HIV. Thank you.
Great, great. Thank you very much, Nancy. I believe we can now take questions from our audience. I can see a couple of people had already left some questions while you were making a presentation. So maybe you could just read through a couple of the questions and address the issues that are being asked. We could start with the question from Anne Beatrice Kihara.
Anne Beatrice has asked, what health promotion preventive strategies have been put in place to break the cycle of PMTCT through harm reduction? And we are working together with the promotion team to ensure we ride on the strategies, on their strategies. We have brought in the CHUs, we have brought in the CHVs, and this we ride on this team because they are the team who are in the community. And we empower them. Like in the last year, through the combo program, we were able to have several meetings for the CHUs and the CHVs and the peer educators. And them being our gatekeepers in the community, we are able to create a link or to have a platform where we are able to understand each other together with them as a community team. So the promotion team have their own strategies in which we've worked closely with them to make sure we slot in the HIV messages or key messages, and we empower the promotion team to be able even to deliver the HIV messages, even in the absence of the HIV team. And I see Jen Nyanga has asked, what point have we engaged the religious leaders in our intervention and how? Last year we were able to have one meeting for the pastors, and I can say you, Jen, I can tell you for free, Jen, that we still have issues with the church. That the church has not embraced the issues of HIV. As much as we were able to get hold of leaders, and that was we had put them in a setup like what we had put for the chiefs, but after that we were not able to really move on because they were not able to to follow up with their work plans that they had. And some of them were asking us if we can plan and not from their side. So we are still engaging religious leaders, but we've already have one class where we took them through an education session, just an understanding about HIV and the profile of the county. So we are still in the process of engaging the religious leaders, but we might not have really engaged them very well like the local leaders, the other local or community leaders. Thank you, Dero. We are really collaborating well with EGPAF, and you see most of the adolescents programs we to do them with EGPAF, with support from EGPAF and the other partners. How we were able to really link up with the adolescents and young people from faith communities. In one of our meetings, we normally don't segregate the infected and those who are not infected. What we do is we allow all adolescents, especially during the party, to come with their friends. And even during those parties, we are able to provide a session for testing for those who have not been tested. So we normally have room. We allow adolescents to come with their friends during their meetings. Those who are comfortable coming with their friends, we allow them to come with their friends so that we are able to reach them during those meetings with key messages about HIV, and also allow them to get, if they can allow them, if they are willing, they can do testing for themselves. We have TWGs for adolescents, and we are working to make them have regular meetings. Brian asked if there is, how are they active? Yes, they are active, but we want to make them regular. We do have them quarterly. And we've also engaged different groups, adolescent groups in the county. Like they have grouped themselves into different teams, and we always, during the TWG, we allow them to come and present their concerns to the county team and the other concerned parties. Thank you. I don't know if there is something that I've missed out, but I've tried to just go through the chat and respond.
Well,
Thank you, Kevin. Back to you.
I do see an interesting question here asked by Caroline Tua. I think she was asking whether user-centered design was employed when coming up with the interventions that you presented about.
Sorry?
She asked whether a centered design was employed to come up with the interventions. I think she's asking whether when coming up with these interventions, was the user at the center of the intervention? Was the user thought about as the end user of the interventions that we're coming up with?
Yes. We thought about the user, and every decision that was thought was at the comfort of, like for the adolescents, we were thinking what can make them, what are they comfortable with? And in most of the meetings that we sit to discuss adolescent issues, we have the representatives, those meetings, who help us get what are their concerns and what do they feel about the 1, 2, 3 things that we want to do with them. So we have adolescents and we have PMTCT mothers at mind in everything that we think to do as a county in relation to their health.
And I believe that answer also covers Caroline's earlier question, where she was asking whether these initiatives were suggested and proposed by adolescents and youth. Rather, I can see it was a joint question whether the initiatives were suggested and proposed by adolescents and youth, or was a user-centered design employed to come up with the interventions. And I think that has been covered adequately. Let's just see if there are any other questions. Anne Beatrice had earlier asked what is the engagement of the adolescents as regards to PMTCT practices and engagement of mothers, mother-in-law, peer support in the continuum of care from ANC, interpartum, and post-delivery. Nancy?
Yes.
Beatrice had asked what is the engagement of the adolescent as regards to PMTCT practices and engagement of mothers from ANC to interpartum and over to post-delivery.
I think most of the mothers that I talked about the red carpet, and most of the mothers that we serve with the VIP cards are adolescent PMTCT mothers who have never been comfortable to be served in the same environment like the other mothers. So we've considered them. If you look at the lineup of those who have given that priority, these are adolescent mothers. So they will really be comfortable, come, be seen, and they go. And other than that, we also make sure we link them with some of our trained healthcare workers who have been trained on adolescent package of care to support them, so that they're not being handled like any other mother. So we have special people and special arrangements for adolescent mothers, and specifically the red carpet targets them, because for the other mothers we've not had issues with them.
Okay, great, great,
And
Nancy. I can see. Mhm.
Beatrice,
Yes, please.
sorry, Beatrice asks if there are other recreational activities for adolescents in the community. I can say yes, but not cutting across the county. In some of the areas, um, we have like ball games. We have times when they will come and play ball games, indoor games, as they are seen. So, but it doesn't really cut across the 81 PMTCT sites. You realize this is like concentrated in town areas, like towns along the main highway. So you will, it is only felt in those areas, but it has not been escalated to the other outcast facilities.
I can see a comment here by Jane Nyanga, and she says, "Thanks, Nancy. Indeed, there seems to be a gap in terms of religious leaders' engagement. We do have HIV messaging booklets by NAC, Faith Sector Working Group, which could be helpful." She goes on to say, in addition, we do have a faith sector action plan which covers AYP issues. We are available as a network of religious leaders living with HIV to journey with you as you reach out to religious leaders. And I think that's really great.
Thank you, Jen.
I think connecting you and Jane would be quite helpful.
Yes.
So I think I could have I'll just find a way to connect both of you and just see how you can journey together in reaching out to religious leaders. I don't know if there are any other questions or comments before we can close this session.
Mine is just to appreciate you uh, and the team and your concerns. And I say that we are just beginning a journey, and we hope in the next in the coming years we will not be having the 8.1 PMTCT or MTCT transmission HIV transmission rate in Turkana County. We want to try our best to engage any necessary person, necessary sector to be able to reach out to all those areas, to all those mothers, and to all those areas where we can get support to be able to reach out to the mothers. In the same way, we want to reach out to schools. So we are just starting a journey as Turkana County, and we hope for the best in the coming years together with our partners. We are very supportive partners, and we as a county are positive. We want to own the whole process, and we want to be able to support our partners deliver accordingly. So thank you so much for organizing this platform for me.
You're very much
Thank you.
welcome, Nancy. Thank you for your really informative and great presentation. We do look forward to having you back on our platform sometime soon, probably just to update us on any new ideas that you and your team will have generated, or just to talk to us about progress about what you currently have going on in Turkana County. So thank you very much for your presentation. I would also like to thank all our participants today. You've been a great audience. Thank you for everyone who dropped a comment, who interacted with our presenter for the day. Thank you for all the questions. I believe they've all been adequately tackled. If not, please drop me an email and I'll be happy to forward the same questions to Nancy and get back to you with a bit of feedback. So thank you very much for participating in today's session. If there are any other comments, I'll be happy to take them maybe within the next 2-3 minutes before I officially close the session. Also, maybe before we leave, we will be having another session in the coming 2 days. We'll be having a session on Thursday around the effectiveness of the Trust Condoms Kuwa True campaign that was being run some time back. So we'll be having a presenter talking to us about what the youth have to say about that campaign. And I believe that could inform future campaigns around the use of condoms. So you're very much invited to participate in our session. It's going to be on 21st, which is this coming Thursday at 2:30 p.m. I will be dropping a link in the comment box telling you how you can join this session. So thank you.